Do I need to? Okay, terrific. I'm going to talk a little bit about TAVR for aortic regurgitation. And I just wanted to start off with this slide, which basically shows that there is no paucity of patients with aortic regurgitation. In fact, according to some estimates, there may be at least as many patients with moderate or more aortic regurgitation as aortic stenosis. And then when you look at the guidelines, in fact, I think it becomes very clear that there is actually no role for transcatheter aortic valve replacement. And as it mentioned in the guidelines, TAVI is rarely feasible, and then only in carefully selected patients with severe aortic regurgitation who have a prohibitive surgical risk. And this, in fact, sort of reminds me of what we used to see with left main PCI many, many years ago. But this hasn't stopped the enthusiastic interventional cardiologist, because every day we are actually faced with patients who have severe aortic regurgitation and are not good candidates for surgery. So what are the challenges in the treatment of pure aortic regurgitation? Of course, it is all about anchoring, and these are patients who have no calcium. They often have large annuli, concomitant aortic dilatation. So it is not uncommon to actually have either embolization or valve migration. Often, as operators, we attempt and overcompensate, and in fact, we oversize it to the extent that we may actually have annulus injury. And residual aortic regurgitation is also an issue with some of these devices. So when you look at the anchoring mechanisms, I think the anchoring can either be at the annulus plus aorta, or leaflets plus annulus. And I would say that it makes the most sense to actually have devices that actually anchor both at leaflets and annulus. So here are some data looking at the off-label use. And this is Sung-Han Yoon, our former fellow. He put together this registry from multiple centers. And what we found was that if you look at the 30-day mortality, and these are patients where the STS average score was actually 6. Now, when you look at the 30-day mortality, even with the new generation devices, the 30-day mortality was 9.4%. So we're all used to seeing observed to expected ratio when we do TAVR in aortic stenosis that is more like 0.3. So, you expect, where the mortality is much lower than what was actually expected. What we also found in this analysis was that when you had residual aortic regurgitation, your outcomes were actually worse in terms of follow-up. So clearly, off-label use doesn't get an A+. Now, when you look at some of these case examples, for example, here is a patient who's 74 years old, has had prior surgery, there is 0 calcium, and, we used a self-expanding valve here, and I think it worked beautifully. In fact, the mitral bioprosthetic valve actually prevented this valve from diving deep. There is no PVL. Patient goes home the next day. This is the echo. It looks spectacular. Here is another patient who's got a VAD, is actually in hemodynamic compromise and has severe aortic regurgitation. This was not a candidate for any therapy, surgical therapy. So here is, we invented our own device here by using a combination of a self-expanding tall frame valve, and we knew that it was going to actually migrate down, but that was better than having a short frame valve that might slip down. And then we actually expand this, and we actually come up with a good result here. This patient did pretty good. Here is a patient who's had prior surgery, David repair, this is all aortic regurgitation. You can see severe AI, and once again, no calcium. In this particular case, we oversized a 29 millimeter valve. We were not able to get this patient into the JenaValve study at that time. And actually, this is the deployment of the valve. And if you look here, pre and post pictures, actually the result is pretty good. And not only that, in fact, this patient has now come back for a 3-year follow-up. These are just 1-year pictures with really good results. So case by case, this is possible. But I think the important thing is that we need a device that is always reliable and performs beautifully with very little residual aortic regurgitation. And hence the JenaValve, or the Trilogy heart valve system. Essentially, what you have here is locators which trap the leaflets between the valve frame and the locators, okay, which allows two things. It allows anchoring, and then it also allows to form a natural seal. So you are actually forming another cuff, a seal with the patient's own leaflets, which will actually reduce aortic regurgitation. It's available in 3 different sizes. So it allows you now, actually, according to the new measuring, we can go up to 92, 93 millimeters occasionally, and in Europe, they've actually done some cases up to 94, 95 in terms of perimeter. So here is just a case example. While this can be done fluoroscopically, the goal here is, of course, to isolate each cusp and the locator, and then, what I wanted to show you here is, all right, so this is the deployment. After deployment, it actually looks pretty good. It is best to do this with the transesophageal echo. Here is another patient where you can actually see with 3 prior sternotomies, we actually performed a Jenna valve. This is a patient who has a VAD. As you can see, once again, this is a significant problem in patients with VAD, and the result was excellent. So this is what it actually, here is yet another patient with an endograft and aortic repair surgery. Once again, there's no calcium here. You can see how this system is able to track up through tortuous anatomy. This is essentially, this valve is deployed through a very long sheath, and you can look on the right side, the results after valve deployment. So very briefly, the results of the ALIGN AR study. So this is a multi-center, non-blinded, it's an IDE study. It's evaluation of the Jenna valve in patients who had at least 3+ aortic regurgitation. Now, there is clinical evaluation and a number of other things assessed at 30 days, 6 months, 1 year, and up to 5 years. Data will be actually collected. So the other thing about this valve system, besides what I already showed you, is that you can actually, through this valve delivery system, you can actually rotate the valve. So you're able to make this valve, in fact, naturally align, so the locators are in the middle of the cusp, so you are aligning the leaflets with the natural leaflets. So this is the study organization, but essentially, patients who were symptomatic and had at least grade 3+ MR, we excluded patients who had aortic root diameter more than 5 centimeter, and the primary endpoint was a safety endpoint. It was a composite at 30 days of all of these things: death, stroke, major complications, but it also included pacemaker implantation. The primary efficacy point was all-cause mortality at 12 months, and these were all calculated based on the previous literature. So this might seem generous, but the 30-day composite safety endpoint was 40.5%. The efficacy endpoint, the goal was to have mortality less than 25%, which was calculated based on some of the medically treated patients in a number of different studies. There was a core lab and, of course, CEC adjudication. What I wanted to point out here is that of the 379 patients, 180 patients were actually enrolled, and successfully a valve was implanted in 177. So a lot of these exclusions were because patient was not high risk or the anatomy was not suitable. So these are the baseline characteristics. As you can see, the average age was 75. The STS score was 4.1. 40% of the patients had atrial fibrillation. So these are the typical, these are high-risk patients, despite the fact that the STS score was actually low. And here are some of the other features. So as you can see that the AR severity was, it was severe in 64% of cases. You can see what the ejection fraction is. And once again, most of these patients were done under general anesthesia. The in-procedural death occurred in 0 patients. Some of the other complications are listed here, which are not very common. 2.2% valve embolization rate. Technical success rate was high at 95%. If you look at all-cause mortality, it was at 30 days, 2.2%. And I think this was all, the primary endpoint of safety was driven by pacemaker implantation, 24%, as you can actually see. But more than moderate paravalvular regurgitation was 0.6% at 30 days. But at 1 year, this patient had mild MR. So therefore, the primary safety endpoint was met, as pre-specified. So was the primary efficacy endpoint, because the rate was 7.8%, and the pre-specified non-inferiority margin was 25%. The pacemaker rate came down during the study from 30% to 14% in the last one-third of the patients. And look at the hemodynamics. They're actually spectacular, 2.8. And look at the gradients, 4.3. So the design of this valve, even though it is intraannular, actually allows for these hemodynamics. And look at the aortic regurgitation rates. Paravalvular AR rates are extremely favorable. So LV remodeling occurred in these patients over a period of a year. So this is, with the AR and TAVR, this is the first evidence, right? Better dimensions, decrease in LV mass, improvement in NYHA functional class, you can see is actually also very impressive. And the improvement in quality of life, KCCQ points increased on an average by 22 points. So to sum it up, to compare, to some of the other aortic regurgitation studies with off-label, I've summed it up here, number of different studies. You can see that only the JenaValve study, all right, the expected mortality was 4, and actually the observed mortality was 2.2. So now we are beginning to approach what we are used to seeing with TAVR with aortic stenosis. And of course, I think we've still got to work on pacemaker implantation. So I think I'm going to basically sum it up by saying that the JenaValve or the Trilogy valve system achieved its primary safety and efficacy outcomes, and pacemaker implantation was the primary driver for the safety outcomes. The hemodynamics are excellent, and there is actually demonstration of LV remodeling in these patients and improvement in what is important to patients, which is quality of life and heart functional failure status through 1 year. So I'm convinced, like Dr. Sharma mentioned, that this valve is going to play a definite role in the management of our patients. Thank you.
Thank you, Raj. We're going to skip over the next talk, which is Samir is running a little bit late, but hopefully we'll get here before this session is over, and we'll move right to Alex Abizad, who has been a leader in so many of our innovative technologies, both in the structural and coronary space, and joins us from São Paulo, Brazil, and is going to talk to us about some of the latest adjunctive technologies.